this is Joel Hughes at Community Link Consulting Podcast, and our guest today is Rhonda Hauff. She is the CEO of Yakima Neighborhood Health Services in Yakima. Welcome, Rhonda. Thanks for joining us today.
Hi, Joel. Thanks for having me. Nice to see you and hear you.
Good to see you too. Just jumping right in. Just tell us how long you have been at YNHS and what motivated you to come to YNHS.
Actually, this January, I celebrated my 41st year.
Wow, that's a long time.
It's a long time.
Congratulations.
Thank you. I survived to tell about it.
Missing a few front teeth.
A few, yeah. Well, let's not say that. Remember, we're on a podcast here, so people might take you seriously there. So as the story goes, and you, I think, already know this, but when I started after I had been at Central Washington University, and I had finished a somewhat short career in student services. I'd worked at a few colleges and decided that I was done working in student services, and came to Yakima and was looking at a couple of different job offers, and I was offered two different positions. One was a bookkeeping position here at Neighborhood Health, and the other was an assistant manager job at a pizza place. And I have to tell you, it was a really tough call because Neighborhood was two little houses that were built in the 30s, and I was enamored by what they were doing, but the pizza place was a little more attractive at the time. But I took this position as the bookkeeper, and thought, well, I'll stay here for a year, because in student services, those are one-year tracks as academics went, and thought, well, I'll do this for a year and see what it feels like. And that was 41 years ago.
So I did not remember that you had bookkeeping experience.
Well, there were 13 of us. And so, I was the bookkeeper, and, so you do bookkeeping and you help work the front desk and you help with the filing, and that's sort of the way it went back then. Yeah.
So you said that the mission or the purpose of YNHS was kind of attractive. What in that was there that attracted you?
Yeah. Well, so my bachelor's degree was in community health education.
Oh, okay.
And so again, because you do a little bit of everything in here, I really had a desire to go into the Peace Corps, and so the work that the clinic was doing, frankly, it looked a lot like the Peace Corps. And when I started, as the bookkeeper, but I also helped with hiring and, helped orient people. And the people we were serving looked like they needed a lot of help.
Yeah.
And so, in fact, when I was recruiting people, one of the things that was kind of my standard lines was, working here is a lot like working in the Peace Corps. You just don't have to give up the running water. And, some days we almost didn't have running water, but it was certainly mission oriented, like we are today. But it felt a lot like, very grassroots oriented, and it had that Peace Corps mission, and we still do. At least our organization, we really are trying to meet people where they're at, and it's what keeps a lot of us here to this day.
Right. Yeah. Well, you, as I recall, you were a lookalike. You were the only lookalike, I think, in the state of Washington, as I recall. And you were a lookalike for many years. And most agencies jump into the grant world prior, as soon as they can. But you remained a lookalike for many years. I don't know how long, but for a long time, which makes life harder.
Yeah, well, actually, even before we were a lookalike, we didn't apply until 1992. So again, this clinic started in 1975. started by a couple of physicians that really wanted to serve primarily uninsured patients. And it wasn't until 1992 that we did the work to become a lookalike, and truly we the neighborhood health staff and we hired a nurse to help us. This was long before the internet. In 1992 we started making phone calls and we sent letters to get all of Yakima County designated as a medically underserved area. That was step one to become a lookalike.
All right.
There were a few census tracts throughout the county who were designated as medically underserved, but we did the work because we had to be medically underserved in order to become a lookalike.
Mm-hmm.
And this was right as Medicaid managed care was coming into Washington State. And so we knew that there were a couple things that had to happen. We were still working out of the two houses. And if we were going to survive, we needed a couple things. Primarily, we were looking for ways to be able to attract and hire National Health Service Corps providers. And so we hired a nurse to help us with the phone calls and the letter writing and to gather the data to be able to get our county designated as medically underserved areas, and we did that. And so in 1992, we were able to get the full county designated as a medically underserved area, and then we were able to apply to become a medically or a federally qualified health center lookalike. So that was a pretty big deal. That was a very big deal.
Yeah, that is a big deal.
And then it was another 14, 15 years in 2024. And then also as a lookalike, then obviously then we were able to apply to for the enhanced Medicaid reimbursements. And we thought we were big time then to be able to get enhanced for Medicaid reimbursements.
Yep. Yeah, there's a lot. I can go a lot of different directions. A lot of questions pop up.
Yeah.
I'll stick to the agenda.
Okay.
So when you look at the lookalike versus the grant world, can you think of any challenges that the lookalikes might have that the grant world doesn't have?
Well, I think, for us, it was a big change because we really operated as such a a grassroots organization. Our board composition had to change. I mean, we took it seriously, and everything that the federally funded health centers were doing, we understood that we had to do as a lookalike. Plus, we had this project officer who made sure that we met all the regulations, and you know who she was, Beryl Cochran.
Yeah.
This is when we first met and were introduced to Beryl, who taught us about regulations and what being a lookalike meant. And so, we by the time we actually got around to applying for federal funding, which was another 12 years, and, there were reasons behind that, which I can certainly talk about, but we were in great shape because we were following all of the rules. The difference was that we didn't have the federal funding for, infrastructure support. We certainly had National Health Service Corps providers. At the time, lookalikes were not eligible for Federal Tort Claims Act or FTCA insurance. That's changed now. But at the time, we weren't eligible for that, but we were eligible for the Medicaid reimbursement, which was extremely helpful for us.
Mm-hmm.
But by the time we were allowed to apply for federal funding, we were in really good shape.
Mm-hmm. So hindsight's always 2020. As you look back and consider your FQHC lookalike versus a grant, do you have any keen insights for agencies that are lookalikes?
Well, I think that once you're a lookalike, depending on the politics of your community, I'd say if you're meeting the requirements of a lookalike, I think that barring other politics or restrictions of the community, then you should be in good shape to be applying for the federal funding. For us, again, for 30 years, we were as poor as our patients. We just didn't have the infrastructure to be able to do some of the creative things that we are doing now. Every weekend for us, we were having yard sales, barbecues, fireworks sales, even to be able to pay the bills. And we weren't able to do the outreach and the engagement that as a community health center we really wanted to do, to be able to find people that really didn't come to us or didn't want to come to us, that we needed to go out and meet them where they were at, figuratively and culturally, to be able to do the work that we wanted to do. I think the other thing that it served us well, it still serves us well, that we were very reliant on our partners. And, as an organization, we have a great reputation, I think, and still do, of being a really good partner. And that has served us well over the 4+ decades of working well with others. We certainly don't feel like we have to own everything in order to provide a needed service for the people that we serve. And that started out of necessity, but even now, we don't have all the expertise that we need in order to serve the people best that need services, and that's okay with us.
Mm-hmm. Now, I've observed you have many partnerships and very good relationships. You're not in an acrimonious situation like some are.
Mm-hmm.
So you're one of 3 community health centers in Yakima. For the size of Yakima, that's a fairly large number of FQHCs. Has that been challenging?
Yes. And I would say this sort of goes back to what I said earlier, is it's been very important to build on the relationships and the partnerships. And depending on who's in those roles in the other community health centers, that, we've been very fortunate to be able to work with some of those other leaders and build on the partnerships and the relationships and what they do best. And hopefully they are relying on us to do what we do best. But there certainly we have had our challenging moments, no question about that.
Yeah. So what's the state's perspective on community health centers? Every state, just quickly, I've noticed many states have a kind of an acrimonious relationship even with community health centers because of the federal rules around them, the complications on rate setting, et cetera. So Washington State, what's been their relationship?
Yeah. Well, from my perspective, we have a really good relationship with the state. And I think this was one area where you would probably get different answers from different CEOs. Our primary influences are bodies like our healthcare authority, Department of Commerce, Department of Health, and it's really the people that are in the state, right, that are in those positions. And I, from my perspective, it's still all about the relationships. They have to work within their framework and their regulations, just like we do. And you have to respect, what they can and cannot do. And for us, it's really the perseverance to understand, where they're coming from, what they can leverage, and we still need to look at what we need to do and what we can leverage, and then we have to work through the system. I think that what we see is making sure that they understand what our rates, you mentioned the rates, what that all encompasses and what it represents. I think as state staff turnover, sometimes it's a learning curve all over again. For them to understand what we're doing, and for us, it's a making sure that we understand where their restrictions are, and then sometimes it means that we have to, talk to different people to kind of find out where our ambassadors are and who can help us make a difference. But pushing too hard against the wrong people, to me, has never been a winning position. It's really about finding the common ground and finding ways to make things happen.
Yeah, good. That's good. On this is a more technical question, but in that that continuum of care, the cost of care typically lands most highly at the hospital level. That's where the biggest costs are.
Yeah.
Is there an understanding at the state level that investing in primary care will hopefully reduce or change that cost curve and reduce the overall cost of care when you invest in primary care?
I think sometimes, I don't think always, and that again, that talks about who it is you're talking with, um, and at what table you're at. And I think one example is, for several years now, I've been on one of the advisory boards of the Health Benefit Exchange. And this year we're talking about plan benefits for the next couple of years. And one of the plan designs that we were just talking about recently was that they're presenting is, okay, well, what if we look at things like no copays and no deductibles for things like primary care, prevention, certain pharmacy benefits. That's pretty revolutionary. We've come a long ways.
Yeah, good.
So
Good.
that's certainly an indicator that there are people in decision-making positions that recognize that primary care is one of the places where you really do save money.
That's encouraging.
Yeah, to incentivize people to do more in primary care and less in secondary or tertiary care.
Good. Congratulations on that.
Yeah, yeah.
So back to partnerships. I remember writing a grant. You had so many partnerships. I remember also sitting in a meeting with your controller, listing all the grants out on the board, trying to figure out how you're going to spend the money. In that process, you had a grant writing process. You had very many collaborating partners.
Mm-hmm.
Can you identify or talk a little bit about how you identified who should be your collaborating partners and who those were and how they fit into the kind of the whole pie?
Yeah. So, again, initially it was looking at the people that we were serving and thinking about what is it that we need that we know that we just don't have the ability to do all within ourselves. And so our initial partnerships, and again, started with people like county government, Department of Human Services, public health, mental health, and this is before we had our own behavioral health staff, our substance use providers, and this goes back to the 1990s, probably, when we were really starting to put integrated care together. Domestic violence providers, our public housing authority continues to be, and these all continue to be strong partners. These are probably our foundational partners that offered expertise that we didn't have. And our whole goal was really to try to build on these relationships so that we didn't just make referrals. We learned early on that making a referral was not going to work for the people that we served. And again, as I said earlier, we didn't have to own the service in order to be able to help our patients. As long as our partners believed, had the same philosophy that we did, that our patients were going to benefit from them. So we oftentimes we just we spent time talking about what they needed, what were their philosophies, and I think you probably remember this is where we termed our collaboratives as siestas, serving individuals to end serious trouble through agency support.
Yeah.
And it was an interagency model that in the end we were we were named a best practice by Health and Human Services, by the Assistant Secretary of Health and Human Services, because of our interagency collaboration. That it involved all these people I just mentioned, the county government and housing authority and the treatment providers, because of our ability to serve clients collaboratively, use a shared database and a shared case management model. And that's been going on for about 20 years.
Hmm.
And part of that was being able to really reach hard to serve families and individuals to be able to take care of our patients. And we continue to do that. And, you know, and particularly with people who serve homelessness as one of our target populations. And we've gotten into the business of permanent supportive housing, but this started long before that. And that's why we started such a strong partnership with the housing authority, because they were in the housing business and we didn't know anything at the time about housing. And so they provided the housing and we provided the support services that went along with that. And, you know, all of these partnerships kind of built on that. They didn't know a lot about, you know, providing the support services. And so we provided it to their clients as well. And those are the partnerships that have served all of us and our community very well.
I see that as really a unique situation
Yep.
in my, you know, small meanderings. Do you see that? It's kind of a weakness or an opportunity that isn't often taken advantage of.
Well, I think we're starting to see more and more of it. You know, over the last few years, this whole concept of you know, now it's called health-related social needs. We used to call it social determinants of health. Recognition that the social needs have as much of an impact on health as the physical and clinical components or genetic components of health. So more and more people are taking stock on those kinds of needs. You know, the director of our local housing authority and I spend more time together. We get asked to come to different communities and present on our partnership a lot, several times a year, actually. So it's becoming less novel, I think, in terms of how we put this together. And I'm thrilled to see it. It's really fun.
Yeah, good. How did you have that vision, or where did that vision at YNHS come from?
So a couple things happened. Again, this goes back to about 2004, when we first in 2004, our local United Way and Yakima County government were kind of the lead of our local continuum of care, which is a HUD term. They were doing a needs assessment on what's the status of homelessness in Yakima County. And they had asked us to come to the table to do a needs assessment and asked us to be the health provider at that table. And the CEO at the time asked me to represent neighborhood health. And so I did. And so out of that, we learned that there really is a homeless issue in Yakima County. We weren't sure that there was. And we weren't identifying that there were a lot of people experiencing homelessness coming through our front doors. And what we learned was that there were some. We weren't doing a good job identifying them as homeless. And those that were not coming in were basically bypassing us and going to the emergency room. So there were two different things going on there. The other thing was, you know, people knew that we were not a free clinic. We were on a sliding fee scale. And so that's one of the reasons that they weren't coming in. And so when we identified and we had data to say, you know, we do have a lot of homeless here, and we had enough information, we recognized we probably needed to develop an outreach team that would go and build these relationships so that they would want to come in. And we couldn't do that without funding. And that's what allowed us to go to our board, and our board gave us permission to apply for federal funding.
Well, out of curiosity, why did they not want to apply for federal funding prior to that?
Well, there was a large community health center in our community who was federally funded. And our board, Yakima is a pretty conservative community, and our board wasn't crazy about the way they were operating at the time. They felt that a federally funded clinic was not community owned and controlled. And that was their resistance. When they saw the needs, they changed their mind.
Good.
And so that was our entree to federal funding. Shortly after that, when we were funded that year, that our first application was funded, again, with the support of our project officer that helped us and provided guidance along the way. And then shortly after that, our Yakima County came to us and told us that a small organization who was providing housing for medically fragile people was dissolving. They'd gone bankrupt. And said, we can't afford to lose this housing stock. So neighborhood, we want you to take these two projects. Comprehensive, you take these two projects, and Triumph Treatment, you take these projects. And so we all said, okay. So that we didn't lose the housing stock. And that was our first foray into supportive housing. Shortly after that, we started developing our programs for specifically healthcare for the homeless. That's what we were funded for, was healthcare for the homeless. And we had a board member that started going out and doing focus groups with our street outreach team, because that's what we were funded to do. And at his very first focus group, he was told, we need a place to be when we're sick. So he came back and brought that information to our board, and our board said, well, that makes sense. Go do that. Go forth and do good things. And so we started figuring that out. And it took us a couple of years, but we developed our first medical respite program. And then a couple of years after that, our providers came to us and said, if you want to make a difference in the health of these individuals, you need to help them put a roof over their heads. So we took that to the board, and the board said, well, that makes sense. Go figure out how to do this. And so, fast forward, we got more involved in permanent supportive housing. And so one by one, mostly we inherited projects from other organizations that couldn't piece together how to fund and support their permanent supportive housing projects. And now this year, we will be up to 200 units of permanent supportive housing.
Wow, congratulations. That's
great. Thank you. And we've cobbled that together, as you know. This is where those very creative pies come together on putting together what funding is available for housing with health services and the support staff to be able to provide those services so that you can make those projects support themselves.
Do you have other physicians, like specialties, that are participating in this, or is it primarily primary care in the healthcare, in the medical delivery side of it?
The biggest projects. Well, I should start by saying, we've been talking a lot specifically about this, but over the years, our federal grants have grown. After about 2 years, when there were additional dollars through HRSA, we did add community health center funding and agricultural worker funding, and then we did also add residents of public housing funding. And so we are full scope. We have everything except for school-based health center funding now.
You have migrant seasonal, right? Do you have migrant?
Yes.
Migrant
Yeah,
funding?
agricultural. That's what I said.
Okay.
And then, we have added behavioral health staff, are a big component now. So, and most recently, we've been working very closely with Pacific Northwest University, which is the private medical school here in Yakima, partnering with them to bring physical therapy into our scope. And very soon we'll be adding occupational therapy into our scope.
Oh, well, good.
So, all services that all of our patients can take advantage, certainly not just those who are homeless.
So if a homeless person lands in the emergency room, how does that person get referred over to you?
Well, different ways. The community knows, and hopefully most of the community knows about us. They certainly all have information about us, but they can also call. And often those, if the condition is one that needs some kind of recuperative care, their discharge planners all know us very well. So they can call our healthcare for the homeless team, and we'll go pick them up and bring them into our medical respite program. That's most typical of what happens. Our street outreach team also, is out there and finds people as much as them finding us.
Mm-hmm.
So, and we have our street outreach team goes throughout the valley and can serve people and find people, whether it's they're in the shelters or in the encampments or down by the greenway or in the parks. And, law enforcement personnel also are aware of our team as well.
Hmm. Are you finding more community health centers are engaging in housing?
Yes. Yeah. And, we're very lucky. I think we are really lucky to be in Washington State. Under the Medicaid 1115 waiver, there are more services that are supported around supportive housing and supported employment. We are also, what's also new, that medical respite care is a reimbursable service. As a housing provider, some of our projects are supported by HUD, but the majority of the HUD dollars really pay for leasing and operations. What the Medicaid programs now provide are what I refer to as the luxury of time, because the people that we serve are mostly all chronically homeless. And so it really gives you the funding to provide intensive case management to help improve health. And that's our goal. It's why we're doing this, is we measure the health outcomes of our patients in supportive housing, and we compare them to our patients in our general community health center population. And for
Mm-hmm.
the last several years, our health outcomes are pretty close of our patients in supportive housing as they are to our general community health center population.
Oh, wow.
We're really proud of that. I mean, the
Should be.
folks in supportive housing probably have 4 to 5 times as many primary care visits as our general CHC population, and that includes medical and behavioral health visits. Again, these are chronically homeless patients, and they have to have at least one chronic health condition that qualifies them to live in our housing. So they're fairly sick people, so it makes sense they would have more primary care visits. But our goal is to help them improve their health, improve their self-sufficiency so that they can live healthier lives. And then we also have certified supported employment specialists that can help them obtain some level of employment as well.
Mm-hmm. Good. Good. When you talked about respite care a minute ago, could you just define that for the audience if they haven't been associated or are familiar with what respite care is?
Yeah. So in terms of serving the homeless, it's a little bit different than what most people refer to as respite care. So medical respite care is recuperative care for people who are homeless and don't have their own home. It's care for people who are sick, but not sick enough to be in the hospital, and for those who are being discharged from the hospital, but not well enough to be back on the streets or maybe not living in the shelter. We provide a bed, typically a room, and it's overseen by a nurse and a case manager. And the case manager is typically a certified medical assistant. They receive daily health checks. They are provided 3 meals a day. We help them get to their follow-up visits with their primary care provider or a specialist if they're following up with a specialist. Help them make sure that they get their meds taken every day. One of the first things we do is to make sure that they're connected to a primary care provider. Oftentimes that's us. If they need any kind of wound care, our nurses typically provide that as well. We typically our standards are that it's a maximum 30-day stay. Sometimes it's more, sometimes it's less. And our average length of stay for the last several years has been right about 19 days.
Oh.
And our goal, we have a couple of goals. The first I just mentioned is to make sure that they have an established relationship with a primary care provider. The second is that when they exit the respite program, we are trying to exit them to stable housing. That's really hard because there's not a lot of affordable housing, but that's certainly one of our goals. And then the third is we track once they leave our respite program, 30 days after they leave our respite program, we're tracking to see if and how many times they go to the hospital within 30 days after they leave us, because one of our goals is to reduce the number of admissions or readmissions to the hospital. It's been the literature shows that when there's an available medical respite program, it can reduce hospital admissions or readmissions by as much as 50%. And so our goal is providing the support and education so that people will return to the primary care provider when possible, rather than unnecessary use of the hospitals or the emergency rooms.
What is your data showing?
Some days are better than others, but some years we have as few as 3 or 4. COVID kind of put a twist on that. Our medical respite program actually has been the isolation and quarantine for all of Yakima County since respite as well. And so we hadn't, that obviously was not on our radar when we started this, but we use the EDI system, the Emergency Department Information Exchange, which covers all of Yakima or all of Washington State. So we can see if people go anywhere in the state of Washington to a hospital or emergency room. And last year, I think we had about a third of our patients went to a hospital or emergency room at least once after discharge. So not as low as we would like it to be, but it's one of our goals that we're working on.
This is an example of investing in primary care changes a cost curve.
Yeah,
that's it
is, and just as an indicator, since 2015, we have been effective enough to get some of our managed care plans to invest in us and to reimburse us, like the Community Health Plan of Washington, which is the managed care organization that's owned by the community health centers, has paid us for rather than paying the hospitals for medical respite care. They've invested in us to be able to support their members when we have them in medical respite care, because they recognize we've been able to show them that for their members that we have in medical respite care, it's much more cost effective and humane for their members because they like being in a more intimate setting with our staff in the medical respite setting than in the hospital.
Good. So those are managed care enrollees then?
Yes.
Good. So how many grants do you have right now?
Well, not counting the size. I mean, some of them are as 30, 40, 50,000, and some of them are larger. And last count I heard was about 66 from our accounting staff.
That's why your accountants are all bald.
Not all of them, but our accounting staff is growing. That is true. That was the last count I heard.
That's a lot to track.
It's a lot to track. But our audits have been good and clean, and so our tracking system is good.
Working. So you have the migrant seasonal farm workers funding, agricultural funding, you mentioned, homeless funding. Do you find the delivery of care to be very different between those two populations?
Not really. Everybody, and this is true for our general population as well. Everyone likes personal and holistic care. Everyone likes one-on-one attention, one-on-one service. And I mentioned earlier, we've really increased our outreach services and our patient engagement to find people where they're at, both literally and culturally. In their communities and their workspaces, and just in terms of trying to meet their individual needs. When the pandemic started, we really kind of looked at who was coming to us and who was not. Our goal is never to leave anyone behind. And so when the pandemic started, we didn't send anybody home in terms of staff wise, because patients were coming to us. And the question was, and our concern was, how do we keep everybody safe? Our patients, our staff. And so we did look at how do we, what is it that we need to do differently? And telehealth really wasn't of interest to any of our patients. And so one of the things that we looked at, but it wasn't really separated by our type of patients, was we had to bring digital health to everybody we served. And there wasn't a lot of difference between our populations. And we continue to work on that. Again, we didn't want our general low-income population, our people experiencing homelessness, our agricultural workers, we didn't want anybody left behind. And so we have invested thousands and hundreds of thousands of dollars and staff time to try to bring digital literacy and health literacy into the worlds of the people that we serve, and let them make the choices whether they want to be part of this or not. But they have the opportunity with one-on-one support. We have a fleet of community health workers now, and that's their purpose for being at Neighborhood Health, is working one-on-one with our patients.
Mm-hmm. Good. Is that department, out of curiosity, is that department kind of broken down to agricultural and homeless, or is it just a single department and everybody kind of
It's
covers each other's duties and
Yes,
knows the
yeah,
roles? And
yeah. It's everybody together. They typically go out together. They work in the same, work on the same events. And one of the things that we, as an organization, we've never believed in and we've never done is work in silos.
yeah, good.
And first of all, even though we've grown to 350 some employees, we still think of ourselves as a small organization. And we've never worked as individual departments, and that has served us well, because kind of one of my favorite, or maybe it's just most common things that I say, is that the vulnerability is always in the handoff. The minute we have to pass somebody off from one person to another, there's always a chance that they're going to drop through the cracks. And so our community health workers, our outreach workers, navigators, we have people with all those different names, but they all know how to do everything. In fact, I've said in a couple of presentations, I used to call them our everything everywhere all at once team. Because if you're a navigator or a community health worker or an outreach worker, you know how to do insurance enrollment, you know how to help somebody sign up for a smartphone, sign up for SNAP, how to get basic health, how to get a health insurance application. They know how to help, and they are your resource. It doesn't have to be by program, because nobody wants to be handed off 5 times to get 5 services, or get a housing application,
Right,
sign up for housing.
Yeah,
It just, nobody wants to be handed off that many times.
good. That's really encouraging. I was having a conversation recently with Peter, a friend, and we were talking about how there's so much division in our country. And you're really working towards a lot of community. That's kind of the definition of community.
It is
Have you
exactly
seen
right.
have you seen kind of positive, not just from the patient population, but from the community population? Have you seen positive outcomes from that?
Yeah, yeah, yes. I've seen the other side too. In terms of, and I think probably the biggest example of that is really with all of our work in housing. There are right now we're kind of going through some of that. I am a very loud and proud proponent of permanent supportive housing. The solution to unsheltered homelessness is permanent supportive housing. And we are probably one of the largest providers now of this permanent supportive housing in our valley. And there's a lot of criminalization of homelessness going on at the same time. And there are people who believe that people shouldn't just be handed supportive housing, they should earn it. And so it takes a lot of energy to kind of have those conversations, but you have to have them. There's still a lot of people that want to complain about all the people on the streets, but when you talk about the solution being supportive housing, they don't want them housed because they haven't earned it. And so those are difficult conversations to have, but you have to have conversations in order to hear people's opinions and to make an opportunity for them to hear yours.
Yeah, good, good. That's a curious question. What's your answer to that question?
Would you rather have them on the streets? Next Friday, I'm going to have that conversation with a group of hotel owners who don't like the fact that we just bought a hotel to help people find housing. So
Yeah.
it's a frequent conversation.
Good luck with that.
Yeah, thanks.
The pandemic was an unexpected and extraordinary event that resulted in rapid impact in many ways. It affected leadership decisions, staff disorientation existed, application of policy had to be addressed, patient access to care was kind of up in the air, IT response to all of that. We could spend all day answering this question or talking about this question. But of all of the impacts, what are 2 or 3 key takeaways that have enduring benefits? And if you could identify those, I think you never know when that could happen again. What did you learn from that? What are the 2 or 3 big things you learned?
First, I would say the importance of communication with your staff, frequent and ongoing, messaging with the staff. I think, one of it, and I'm going to attribute this, one of my colleagues from another community health center, Angela Gonzalez from Community Health Center, said it best when she and I were presenting at our local accountable community of health last year. She made the comment, she said, if you don't tell them what's going on, they're going to make it up. And I just thought she was so spot on. And so I think just ongoing communication about what's going on, what we're doing about it, I think is so key. And my personal style is whenever possible, throw some humor in it, because that's what helps me keep going. So gentle, smiling. Mine was always ended with a Dr. Seuss limerick. I don't know why, but very early on, I would end whatever I was talking about with a Dr. Seuss limerick, and it stuck, and the staff seemed to like it. But frequent communication was very important. I think being real about what you know and what you're planning was really important, and not being afraid to step up and help. One of the things that the pandemic did for us was being recognized again. We have a niche for serving really vulnerable populations in Yakima, particularly in the downtown corridor. So we were being called on by public health, by FEMA, again, our medical respite program became isolation and quarantine for all of Yakima County. And all of a sudden, our staff was being recognized by, the business community, who often doesn't always see us in favor. Our public health continues to call on us, but really recognizing us. We were immunizing, providing COVID vaccines. The Holiday Inn, the hotel across the street, donated their banquet rooms
Oh, really?
for
That's cool.
weeks because they weren't doing any banquets or conferences. So they donated their banquet space for us to immunize the community. But they really, acknowledged, and the community really acknowledged the work that our staff was doing to keep the community safe. And that was just an acknowledgement that when somebody called and asked, we did everything we could to say yes. And that has gone a long ways, and I think they still remember that. So, just not being afraid to step up and say, yes, we can help, and we want to help. This is our community too. So I think that was really important.
Huh. So a question comes to mind in regards to the business community. Do you have pretty good working relationship with the business community, and do you have an open dialogue so you can address some of the obvious kind of concerns that they might have while addressing and getting an ear to hear the concerns that you have?
Most of the time, yes. Again, we've been downtown Yakima we've been here for 40 plus years, 45 years. And so with some, we have a very good relationship, and, there's always going to be a few naysayers. I have a couple of board members that have been on our board for a very long time. And I can't say enough about how important it is to have a board that has your back.
Mm-hmm.
And they have been great about, some of them are part of the Rotary clubs and other service clubs that has been extremely helpful. And again, you never know where that support is coming from. There was an article this week, actually an editorial, a newspaper article and an editorial about us. And, when you're talking about homelessness, you're going to have lovers and you're going to have haters.
Yeah.
And we've had some great support, both financially and philosophically. And many of them are from the business community. People want to support us. One of the other projects that we have is a mobile hygiene unit, and we park it at some of the churches where people can come and take showers, because we don't have we don't have any public hygiene facilities in all of Yakima County. And so a few years ago, we bought a public hygiene unit, mobile showers.
Oh, really?
It's called Neighborhood Showers.
Huh.
And the love that comes out of that. And some people, we get a few naysayers, but I looked on our website a couple of weeks ago and there were 500 shares
Oh, cool.
on our
That is
Facebook
good.
page.
That's neat.
Because
That's a
people
great
just love
idea.
it. Oh, yeah,
Was that your idea?
it was.
That's a great idea.
But we've been talking about it as a community for 15 years, and we finally had an opportunity to just buy it, and so we did.
Oh, good.
And people will donate money because everybody gets a fresh set of sweats and underwear when they take a shower. And then we have a staff there of our community health workers and a nurse and behavioral health that are there. With the whole point is to engage people to see if we can get them into services while they're waiting for their shower.
Yeah.
And it's working.
Yeah.
Certainly not with everybody, but a lot of people have come into services as a result of either waiting for their shower or after taking a shower.
Cool. That's great. Good. So you've seen a lot of changes over the years in healthcare delivery. What are a couple of big takeaways?
Well, especially right now, because you're asking this question right now, I think my takeaway is the more things change, the more they stay the same, or the more when you think you figured them out, you can count on the fact that it's going to change.
Yeah.
Um,
That's a good lesson we should all learn.
yeah. So, the example is community health centers. We've been working on patient-centered medical homes for a long time and incorporating social determinants of health, finding ways to incorporate ways to pay for those social determinants. And we've been talking about those kinds of things for an hour now, I think almost an hour. And now we're going through some new structure that we're still trying to understand through both Medicare and Medicaid, called Making Care Primary. We're still trying to understand exactly what that is. And we're trying to figure out, what is it that we might have to leave behind, or what is it that we want to make sure that we maintain the foundation for, and what that's working. But we want to make sure that the payment structures are going to follow so that we don't have to dismantle the pieces that are already working.
Yeah, good. Good. Do you find the hospitals are participating in the dialogue?
Well, not at the tables that I'm in. I'm sure they're there somewhere, but that just based on the term "making care primary," the tables that I'm at are primarily focused on the primary care piece of that. But I'm sure they're there somewhere.
Yeah. Hmm. Okay. Uh, let's see. I've known you for a long time, and a couple of things that I've observed. One is you work a lot, very hard worker. Come to work at 6 in the morning, and you'd be about 30 seconds later, I'd get a reply to my email. That probably hasn't changed. You're very intelligent, and you are not arrogant or judgmental. Of these, what was the most important to your success?
Well, first of all, that's very kind of you.
Yeah.
And honestly, I would say that any successes that I've had is probably most attributed to surrounding myself with people who work hard, are intelligent, and are not arrogant or judgmental.
Good.
And you're one of those people.
No,
Uh,
thanks.
that the work that we do, it has to be rewarding. For me personally, it allows for things like creativity, which is one of the things that I love. I've never had a boring day in 41 plus years. And it also, this is the kind of work that usually draws a lot of nice people to work with.
Mhm.
People who truly are in it for the mission. I know there's other people out there, but I don't work with them.
Yeah. Yeah. So you are involved at the national level on healthcare for the homeless issues, housing. What is the dialogue going on nationally around community health centers?
Well, specifically to the homeless, so much of what we're talking about right now is around criminalization of homelessness. How do we support and take care of, people who are so vulnerable? And I mean, that's kind of heartbreaking, honestly. There's right now, I'm gonna make this conversation somewhat time sensitive, but there's a Supreme Court hearing coming up in just a couple weeks, about whether or not it should be criminal for people to sleep in public. Our organization, we just signed on to an amicus brief, a friend of the court paper on the detrimental effects of people not being able to get enough sleep. It's a public health concern. Um, and we just had our policy director from the National Healthcare for the Homeless Council came and talked to um, our local homeless network this week, about the number of cities. What did she say? 50% of all cities across the country have laws against sleeping in public, or sleeping in city parks, or some kind of laws against loitering in public if you're homeless. I mean, that's incredible. we have not had a lot of progress there. And I've been talking a lot about a podcast series on NPR, and the Seattle Times has running about, it's called The Lost Patients. And it's a series of 6. The 5 of them have already have run. The 6th one is coming out in the next week. But it's really about mental health and specifically schizophrenia. But it's about the deinstitutionalization of mental health conditions. And it is and you know, the result of so many people who were at one time were in mental health institutions and are longer, and how many of them have ended up homeless. And it is so it brings to light so much clarity of why we are in the position that we're in. And it's like, I just want to turn it on to every person, to everybody, as they go to bed at night and have their REM sleep absorb it. Because I think it just explains so much. And you know, I always thought that the deinstitutionalization started with President Reagan, and you know, I was wrong. It started with President Kennedy because of his sister, who was a schizophrenic, and he really had a goal of bringing severe mental illness to the community, and he created community mental health centers. But then he was assassinated, and he didn't get to finish what he wanted. And then, you know, so many things happened that the infrastructure wasn't built the way that he had envisioned. And so many people with severe mental illnesses, then, you know, fast forward a lot, were left out on the streets to fend for themselves. And I look at so many people that we at Neighborhood are taking care or trying to help, and trying to help get them into housing, but there's not enough housing. And, you know, 70% of the people that we have in supportive housing have a chronic mental illness. That is the illness that qualifies them. And it's just like clear as a bell to me when I listen to these podcasts. So that's, you know, that's what we talk about at the national level, is the criminalization, and what, you know, what is it that we can do. And then of course substance use is part of that too, but it's a much smaller percentage of people with substance use than it is with mental illness. And I think that is such a misnomer for people that don't work with this on a regular basis.
Good. Is there a general support congressionally of the community health center movement?
There is, and there has been for a really a long time, bipartisan support. You know, the community health centers, I think, are recognized at the federal level on both sides of the aisle as being good stalwarts of public dollars, and being a solution to the primary care access issue. And I think we have enjoyed that for a very long time.
Right. Good. Yeah, I would like to know, but it's always felt to me community health centers are one of the best federal investments out there, because they take a limited amount of money and they leverage it for services that go way beyond what, oftentimes a grant of that size will do in another agency under a different program. So as you look back over your 40 years, what are a couple of experiences you could share? 40,
Well,
40, what'd you say, 40?
I just finished 41. No,
41.
No, the clinic's been here for 45, almost 50 now, but
Yeah.
I've been here a little over 41. So I thought about this, and so what I think is, what came to mind a few years ago, I heard someone say, optimism is the belief that your behavior matters.
Yeah.
And so I've shared this several times since I heard that, and one of my providers actually made me a plaque with that saying, and it's
that's
here in my
good.
office.
That's a great saying.
So every day, I think that I have the opportunity, or anyone that works here has the opportunity to do something that truly can change either the course of one person's life or the health of a community. And I think that's profound.
Yeah. Cool. That is good. Good. Thank you for sharing that.
Yeah, you're welcome.
So it's like there's a constant evolution that's in place. Where do you see YNHS in, 2 to 5 years? Because this isn't ending. I mean, you don't get to the end and go, okay, I've done it. It's working. We'll just
Yeah.
leave it alone and nothing else happens. And you're not the kind of person that would do that.
Yeah. Well, in the next, so we just had our strategic plan session. Our most recent one was this last fall. So I was looking through that in anticipation of this. So in the next few years, first of all, that will happen in the blink of an eye. I'll
Yes.
feel like that just happened. So by then, we'll have completed our new dental training clinic. We are building a dental clinic in Terrace Heights that is in partnership with Pacific Northwest University. And so we're going to be a dental training clinic for the first time. We'll have graduated 4 cohorts of nurse practitioner residents.
Oh, cool.
Blows my mind away.
That's great.
And we'll have added at least 50 more units of permanent supportive housing. So that will, that will make another dent for our homeless population. And with any luck at all, we will also have increased access for primary care for our residents in Yakima County, which will, improve and increase our workforce of primary care, which is really the heart of who we are.
Mm-hmm. Is recruiting is recruiting getting any easier, or is it still really hard?
It's really hard, particularly, which is why, we have formed this partnership with Pacific Northwest University. We have their medical students. Now we're going to have their occupational health and physical therapy students. But we are working with them, Yakima Valley Farm Workers and CMAR. We're each building dental clinics, and we're going to have 22 residents each, or dental students each,
Wow.
and a year, and the D2s, D3s, and D4s in each of our clinics. We're us in Yakima, Farm Workers in Kennewick, and CMAR in Tacoma,
Hmm.
with Pacific Northwest University faculty to raise and train dental students for rural and underserved populations.
Well, that's great.
Yeah,
That is good.
we are excited about that.
Yeah. Cool. Do you let's see, do you see any impactful changes occurring within or outside this niche that are coming down the road?
So, as kind of the wave of community health centers and the leadership across the centers have been kind of moving in and moving out, what I see is that the community health, and this goes back to your last question, I think, just about community health centers in general, that I think that I don't know how much you have been working with the centers across the state of Washington, but what I see is that we have really started to gel and build a strong network of services over the years, especially recent years. And we've become a really important partner within our state to serve our low income and most vulnerable populations, including people on Medicaid and low income Medicare, the dual eligibles. I mean, these are all populations that our state is really focused on. And we've been talking about a lot of the special populations in this last bit. The Healthcare Authority, Department of Health, all of these support our health services. We've built, I think, collectively some really good relationships, going back to your earlier questions, but also organizations or agencies that we haven't talked about, like the Department of Commerce, that has all of these new programs that are supporting marginalized populations around health literacy and basic needs and those kinds of things. DSHS and the Office of Superintendent of Public Instruction that are working to help bring educational services in for the people that we serve. They're all working closer with us with the community health centers now to support public health and health-related social needs. So as our populations move across the state, they really see us as vital partners to work with the people that they're trying to lift up as well. So I see us, the CHCs, as the neighborhood safety nets that we were envisioned to be when we were created back in the 60s. And I'm really proud that I've been part of that.
That's great. That's really cool. That's a whole nother world out there, opportunity.
Yeah.
Yep.
And that's all starting to gel. And again, as the state is starting to reach out more from these different agencies that have not really recognized us over the years, I see that more and more is happening. And I think that is really cool.
Oh, that is cool.
I think that's really cool for our patients.
Yeah. Yeah. The question, probably the last question I have, you can elaborate or expand on anything, but over the years, you've been here for a long time. You've seen a lot of the maybe not quite, but close to grassroots CEOs, retiring, moving on. And as we look at the new CEOs coming in, do you see they have a vision for or an understanding of this population and the kind of the community health center niche? Or is it much more business oriented and kind of bottom line oriented than it maybe was 20, 30 years ago?
I think it's both. I think that I kind of think that there was a wave that 5 years ago I would have said, oh, they're all very business oriented. Now I think it's kind of swinging back. I think of the group that are there now while I'm there, that I think they are, I think the group that I sit with right now are much more mission oriented, but there are some that really do see this as a business. That maybe don't have the history or didn't have the history, but they still are mission oriented. But there are definitely some that see this as strictly as a business and only as a business. But part of this, I think, in terms of the mission side, I think has to do with our network, our community health network, and the leadership there that is constantly reminding us of the mission and who we are. And I think the CEO at the network gets a lot of credit for that, because she is constantly talking about the mission of the network. And I honestly do believe that she gets a lot of credit for reminding us of who we are. 5 years ago or 6 years ago, before she was there, the people that I saw at the table, and there's been a lot of turnover, probably 3 years ago, there were just a whole bunch of different people there. And I think they just didn't have that constant reminder.
So are you saying some of those people that came in as business oriented are now becoming mission oriented?
No, I think most of them are gone.
Are they? That's funny.
Yeah.
All right. Well, do you have any final comments that you'd like to make?
No, I don't. I think you were very thorough with your questions.
All
Maybe
right.
I was just too thorough with my answers.
Oh, you were really great. This has been a lot of fun. It's a good update. I haven't been in the niche for a while, so very educational. Thank you.
Ah, well, you'll have to come over and have dinner sometime.
I will. Yeah. Thanks, Rhonda.
All right.
Appreciate it. Have a good day. We'll talk to you. I'll give you a call when I'm coming in that direction.
That'd be great. All right.
All right. Thank you. Bye.
Bye.